DNA. I will be making forward-looking statements, so please be aware of this disclaimer. And I also did want to say thanks to the Invest in Bavaria conference for hosting this. I appreciate that. And just by way of my background, I was an equity analyst for 16 years and liked the company. I was covering the company, liked the company, and liked the management team, liked the technology, so I joined. And now I'm doing investor outreach for the company. So our goal essentially is to impact the standard of care for cancer. We improve treatment outcomes. We're setting out to improve treatment outcomes with our non-invasive cancer diagnostics. These are molecular diagnostics, meaning they're at the the core of we'll say scientific advancement in cancer. They're at the DNA level, and again, non-invasive is also a key term. But I will say, as opposed to diagnostics, the classic sense of determining whether somebody has a disease, our technology is really focused on monitoring cancer and treatment progress. So the company overview, again, our precision cancer monitoring technology focuses on non-invasively tracking the mutations that drive cancer, validating our technology, numerous collaborations with leading centers, 30 ongoing clinical studies, and with 17 of the top cancer centers in the United States, 17 NCCN cancer centers. And we have a significant patent portfolio, which I'll touch on, and we are what we call a CLIA lab model. So, in other words, a sample is taken, it gets sent because it's typically urine, and it'll be sent to our lab. We'll process it there in our lab and then give the result to the physician. A very experienced leadership team, our CEO, CSO, Chief Scientific Officer, and CFO, all have been at companies together, very successful companies like Sequinome, AviRDX, Acturus, and they've had some successful exits too in the space. One of their technologies, the one from AviRDX, is being reimbursed at $3,000 per test, very high level, very value-oriented diagnostics. So these guys have done it before. I introduced myself. We have a level of experienced VP people backing up the senior team, and a very strong board of directors. Paul Billings, listed number 2 under our advisors and on our board, was the Chief Medical Officer at Life Technologies, which was recently sold to Thermo Fisher. I should mention here also that we are a publicly traded company. We trade on NASDAQ, NASD, and under the symbol TROV for Trovagene, and we're about $100 million market cap. So the problem that our technology addresses is the understanding of cancer, and cancer being driven by DNA mutations. In addition, tumor biopsy, which is really the only way to get a mutation today in cancer, is plagued by heterogeneity, meaning that within a tumor, or from one tumor to the next inside of a person's body, there's varying tissue and components of the tissue. So if you're taking a biopsy, you don't always get the information you need. On the other side of the ledger is the rise of targeted cancer therapies, therapies that are directed specifically at certain receptors, in this case specifically at certain mutations. And those therapies are very effective, also very expensive, and have a lot of side effects and so forth. So being able to use them appropriately is key. So in the middle is what we need. We need monitoring at the genomic level, at the DNA level. And so what's available today? What are we competing with? We're competing with the way cancer is monitored, which is primarily imaging, medical imaging. As you can imagine, size of the tumor only. It's a rough size. There's no molecular information. There is radiation, but if you have metastatic cancer, that's not really the primary worry. The key is getting the information. And we have radiologists. I actually have a radiologist from Kaiser that's a shareholder. One of the reasons he's a shareholder is because these radiologists and some of our clinical investigators that are doing work on our studies, they want the information before it shows up on the radiograph. It shows up on the radiograph, you're seeing tumor growth, you're already progressing, right? We want to see the molecular information in advance. And these are radiologists in the field that are telling me this. So I love when doctors are telling me they like the technology, they want the technology. So tissue biopsy, again, you can get genomic information. You don't monitor this way. You don't keep rebiopsying. It's very expensive. It can be very risky. Brain cancer, for example, lung cancer. Some cancers, you can't even get a tissue sample. Circulating tumor cells, not a lot of data on these being very correlative to progression of disease. So you're looking at the whole cell, not the DNA like we are, or the mutation like we are. But again, these haven't proven to be good ways to monitor cancer. And traditional blood markers, enzymes and cells, again, not specific to the cancer. Oops. Okay. So big market opportunity. The imaging market alone in the U.S. is a $12 billion market as of 2010. The way we look at our market is about 525,000 cancer deaths. Again, U.S. only. These late-stage cancer patients are getting 8 to 10 images per year, about $1,000 an image, approximately a $5 billion potential market. We're not saying that we're going to replace imaging or biopsy. We're going to initially work with the standard of care and be alongside of imaging and biopsy. But over time, you could actually see our technology being used in place of biopsy, in place of some of the images that are taken. Perhaps all of them, but we're not promising that, and that's not a way to get into the market. You want to work with this current standard of care. But the physicians are asking for information at the molecular level, because when they do this, they know they're targeting the specific driver of cancer. So a little bit on the technology. So you have the tumor cells themselves. They die. They release their DNA into the blood circulation. They travel around, and you can either get a blood sample with DNA, or you can get a urine sample with the DNA as well. One of the, don't have it in this slide, but one of the core competencies for us is we've been working with urine for a decade. Before we became Trovagene, we were a company called Genomics, based here in Manhattan. Now they're based in San Diego. And for that period of time, we were studying DNA in urine. Nobody else was, because nobody believed it would be there. And based on the sequencing technology, that was very expensive, so nobody believed it would be a commercially viable assay. Now you've had the steady rise in sequencing, and sequencing has become significantly cheaper, right? From a $50,000 test to a test that might cost a couple $100. So why urine instead of blood? Plasma, you get a 5 to 10 ml sample. You're not going to keep taking samples over time. So in urine, so per ml, per unit of liquid, you're going to get more DNA equivalents. But if you think about a whole urine sample, which is anywhere from 50 to 200 mLs, you're talking about 5 to 25 times the size of a urine sample plus frequency. Much better chance of seeing that needle in the haystack. Bring in more haystacks, increase the size of the haystack, I can find more needles. It's completely non-invasive, and it can be done at home without the aid of a healthcare worker and sent right into a lab. And we do have instances where a doctor has said, with some of our sample kits, I have to wait for my patient to visit. We said, no, we'll send her a sample kit, and she'll send it to our lab, and we'll send you the result. Okay, so why cell-free DNA, or here we call it ctDNA, which is circulating tumor DNA. Same thing. Cell-free DNA would apply to other diseases, other DNA. Circulating tumor is the DNA in the tumor. So Francis Collins, director of NIH, cancer is a disease of the DNA. New England Journal of Medicine was the first study to really show that circulating tumor DNA was the best marker of disease. Not circulating tumor cells at the end of that statement, and not the CA15-3, which was another marker for breast cancer. Best thing is, look at the DNA mutations. That's going to tell you what the cancer is doing, whether it's getting better or worse. And that used to be our slide, and I've added this panel on the right, which is data that we presented at the major cancer meeting, ASCO, in June. And this is our investigator from MD Anderson, and his quote is, "Statistically significant correlation between mutation response and treatment response." So, in other words, if the mutation is going down, and I have some data to show you later, the mutation is going down, the patient is responding. If the mutation levels are going higher, they're not. And that's intuitive, but up until our technology, you weren't able to see that. So that's the gist of what we're doing. This is our technology. Some people ask, what do you actually have? What do you sell? And we are in the very early stages of commercialization. I'll make a note of that. But it's basically, it's IP and it's processing. It's a service, essentially. So a sample comes into our lab. We extract and isolate DNA. We have proprietary methods for that. And what that graph is showing is that we're going from DNA with varying lengths, the x-axis all the way to the pointer here. This is length of DNA material. So we screen out the longer pieces of DNA, get to those short pieces, and that's important. Size of DNA is very important to our intellectual property. We do that because the short pieces are coming from the systemic circulation. They're being chopped up and they go through the kidney. So that's part of the secret of what we have. So we do that first. Then we enrich the mutant allele. What that means is the sea of red squigglies, that's natural occurring the gene. So the gene is not mutated in those, what we call wild type, and the little blues are the blue squigglies on top are the mutation, and we put them through a process where we suppress the wild type and amplify the mutated DNA, and that's there's a lot of IP around that, number of patents. And then importantly, we're platform agnostic. We can use different platforms, but we use the next generation sequencing platform from Illumina. We do have a partnership with Illumina. And then also we have a very high sensitivity down to single molecule detection. So our patent portfolio, over 160 patents, pretty good for a smaller company, all along the continuum of what you need to do to get out this DNA and analyze it. Importantly is that one that says 20 to 50 base pair, tRNA is transrenal, so it means it passes through the kidney family. So we're looking at systemic DNA mutations that go into the kidney and into the urine. Term out to 2029. That's key because when those fragments come through the urine, reading those small fragments of DNA is very important because that's what's in the urine, number one. And number two, we block competition out because we build primers. Primers amplify that DNA. They make more of them so you can see them in a DNA sequencer. And when you have very short pieces of DNA, you have to put the primers, land them like on an aircraft carrier. So there's only so much real estate on the pieces of DNA, and we've patented all around that, all the different sequences and all the different pieces of real estate, placement positions. And in doing so, we think we've blocked everybody out of being able to do this in urine. So clinical adoption first, and this is where I'll differentiate from qualitative and quantitative. Qualitative is we can actually see the mutation, and you can say it's there, and number one, the reimbursement is a little on the low side, but and it's not that, again, you can take a biopsy in most instances. Where you can't take a biopsy, you could use our technology. That's about $100, $200 million revenue type of market. But quantifying is where we are, and few, if any, are where we are. So again, what we're doing is we're not only seeing the mutation, but we're also saying how much mutation do you have over a period of time. In other words, is the mutation going up or down? And that's very important in terms of driving clinical adoption. We think that's worth over $500 million, and certainly increases the reimbursement as you talk to insurance companies and Medicare, saying that we're going to quantify the mutation over time. And here is still doing the same thing. The third, stage 3, which is multi-billion, is taking that and proving it in clinical trials. Are we helping patients live longer and do better? So health outcomes. And then are we saving money by preventing the overuse of some of these cancer drugs? And we should be getting to, so we've, okay. Again, a testament to what we're doing is in demand. Memorial Sloan Kettering here in the city, MD Anderson, Dana-Farber, Northwestern, US Oncology, big partners in the cancer area and more to come, are all doing trials with our technology. And that's how that's our path to clinical adoption and to use. We don't need FDA approval today for these tests. We validate them in our CLIA lab, and once they're validated, they're able to be used because they don't get ingested into a person's body. They're just used by the clinician to direct therapy. We've presented a number of clinical studies to date, where it says 2 ASCO presentations. In June, those were kind of our bigger studies to date. We're focused on a series of mutations right now. We expect to have 10 by the end of 2015. We have 2, the KRAS and BRAF. These are specific types of gene mutations, and they apply to a number of different cancers. So KRAS and BRAF will be melanoma and pancreatic and colorectal. So we have the coverage of those tumor types. We'll have something for lung over the next couple of months. And every time we release another mutation coverage for our platform, the stock tends to do well. Typically can go up from 50 cents to $1. A lot of ongoing studies. I mean, to really lead in this space, you've got to do the trials, you've got to generate the data and get out to physicians. Seminal studies, I'll call them. In the middle column, the pancreatic cancer with US Oncology Research, USOR, melanoma, Dana-Farber, lung, which is with a pharmaceutical partner for EGFR, and then the top one in the bottom group down there, colorectal cancer. Those are going to report out, we expect, sometime next year, potentially by the middle of next year, and we'll have data presentations at ASCO, the major cancer meeting. And that should fuel uptake. We'll hire our first 6 sales reps along with those data to be at the meeting. This just demonstrates that we are receiving samples in our lab, meaning that in the clinical trials we are getting more uptake. So there's demand, and then also some of that is in our R&D as well. Here it's just a little bit of data on our KRAS. Just the main point on the bottom is 94%, whether you compare tissue to urine, plasma to urine, meaning blood to urine, or the tissue versus blood. Either way, you're 94% or higher, very high sensitivity. Clinicians will be happy to use an assay like that to detect and track mutations. This shows a little bit of clinical utility. I think this is very important. So this is what we referred to before about this statistically significant correlation. So on the right, down the bottom, where it says RECIST criteria, that's where we showed the mutation levels correlated with treatment response. And that's a p-value of 0.002, highly statistically significant. And on the left is really clinical utility. So you can see for patients where the urinary mutation was increasing, the arrow going up, they lived a median of 61 days. And the patients where the BRAF mutation was decreasing, they lived a median of 259 days. So clearly, trying to work on making sure that mutation level is down is going to give you longer life. Very valuable. And this is really a first. Nobody really has this kind of data. So this is a different in histiocytic patients. The quick of this is if you look at those two charts, the top is tissue. They were able to, with a biopsy, tissue biopsy, they were able to identify 15 people with the mutation. Down the bottom, that chart is reversed, by the way. It should be a bigger shaded area for 16. But they were able to identify one more patient with the mutation with the urine, with our test. And going back to the top, tissue was indeterminate for 9 patients. We saw everybody as either having wild type, so non-mutated versus the mutation. So we're better than biopsy in this case. And that on the right is just showing what it looks like the mutation level is going down when they're treated with the therapy on top, dabrafenib, which is a BRAF inhibitor therapy. This shows anakinra. They were on a medicine that was effective. They came off for toxicity. The mutation spiked, and we got them back on another BRAF inhibitor, and the mutation came down. Within 1 week, we were able to see the mutation spiking, so very valuable. For commercializing right now, to the end of this year, we've been preparing the market. We've been targeting key opinion leaders. We have an investigator-sponsored study, so all these institutions we're working with. We've been doing some branding and awareness through the internet and journal publications. We have the data that we've been presenting at medical meetings, and we just got another manuscript of data that's published. And next year we'll be in full commercialization where we'll add those 6 sales reps. Back to the left, we'll get more mutations out, conversion of our research collaborators to actual adopters. We'll start to get sales, new market segments, and new ways to use the test. What I love about this technology, physicians are calling, we're giving them sample tests in that histiocytic disease segment, the BRAF segment, and they're saying, hey, can you send me more samples because I have patients with these other cancers that have BRAF, and we want to monitor those. So even that we're looking at certain cancer segments like we listed, but the doctors are coming back to us with new uses. So the more mutations we get out there, we think the market is bigger than what we can conceptualize. And that's just what you can do. I think most importantly is the middle box there, emergence of resistance. So it's not only the mutation you have on biopsy, but it's also over time a mutation can appear, and knowing when that mutation appears is going to change the course of therapy, because there's either a treatment for that or the treatment that a patient is on will stop working. And so that's a component of our study. Very valuable information, and again, you'll know that information way before you'll see in a radiographic scan. HPV, we just had good data on this test. It's separate from cancer monitoring, not for the U.S., for emerging markets where there's no infrastructure, there's no cervical pap smears there, so very big market, and importantly, we're looking to partner that assay out. Cash flow very quickly, most importantly, down all the way to the bottom right, 34.7 is our balance sheet at the end of June, so we don't need cash at this point. And just on the top, about 11.5, 11.8, will be about 12 million in burn this year. So 34.7 gets you a little under 3 years of cash. So well capitalized. Last slide will be the catalysts, and then I'll wrap up. So continue to demonstrate the clinical utility. We have meetings coming up toward the end of this year, more medical meetings, journal articles in medical journals, more mutation coverage. As I said, when we launch those are pretty special for the stock. We'll have new collaborations, medical collaborations to run clinical studies, more industry partnerships like we have a partnership with Illumina. the HPV deal that we expect to do, and we're looking to drive sales with early adopters with the tests that we have. So I appreciate your time. Thanks so much. Sorry we don't have time for questions, or do we? Okay, we could take a question or two. Yes, sir.
What's your thinking about potential changes in the CLIA waiver, and how it would impact the model, particularly where you're guiding therapy, it sounds like?
Yeah, that's a good point. So the FDA is proposing to regulate the CLIA industry. Right now it does not. Number one, it could significantly clamp down on investment in the space. Because I know, as a financial professional, I've helped with the modeling, it's already a very tough business model to run a CLIA lab, R&D, and a sales and marketing program, to add regulatory. So in a way, since we're capitalized and we're a public company, it can crimp off competition. The other thing is we're in the lead. The products that are on the market are going to be grandfathered, right? And in addition, there's going to be a 10-year phase-in of those guidelines, so we have time to really get tests out there. And the other question is our test high risk, right? If we've really driven the clinical data through real clinical trials, and we have evidence that we plan to drive longer term, that we are really truly helping patients, saving money and so forth, then we may be doing enough now to avoid the regulations. But for earlier stage companies, academic institutions are using blood. I think it's going to be very tough for them to get funding if these FDA rules come into play.